for yet another webinar in the Cutting Edge webinar series. Cutting Edge is a platform so that POGS can interact with other societies in Maharashtra and rest of India in an attempt to reach out to everyone. So today's webinar is in association with Ahmednagar Society. I welcome all delegates, esteemed faculty for this webinar once again. Let's begin the webinar by taking blessings of the Almighty. Can we have the prayer song, please, Mr. Nandakishore?
कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Thank you so much. Thank you. Hello, good afternoon, everyone. I'm Dr. Shubhangi, a fetal medicine and gynec consultant from Pune. I welcome Dr. Aarti Nimkar, madam, who is President POGS. Ma'am, may I request you to have few words? Please display Dr. Aarti madam CV, please.
Don't worry, don't. It is not required.
Yeah, Mr. Nandakishore, please.
Yeah. I welcome you all, the faculties, delegates, and eminent guest of honors of the Ahmednagar Society. I am very happy that we are joining this week with the Ahmednagar Society and interact with them. And I think it is a very good program of the Cutting Edge. We are taking every week on the Thursday now. And since last year, it is going on very hit on the platform. And many societies are communicating and joining with the POGs, and we are sharing their views and presentations and what are we newly doing. And now Vaishali Chavan is a very eminent speaker every week, and we are promoting this for her presidential candidature for the Foxy VP Presidential Coalition. I welcome you all. Welcome our own Mukta Umarji Madam as a past president for the guest of honor, and Josna Dhawle Madam from the Ahmednagar Society. And the speakers are the Vaishali Chavan and Ganesh Bade sir. And our chairpersons are Dr. Anish Bendre, Dr. Amit Karde, and Renuka Pathak and Swarna Madam. Welcome you all for this webinar, and enjoy the speakers. Thank you.
Thank you so much, ma'am, for the quick introduction for the webinar. I request Dr. Vaishali Chavan, madam, who was our past chairperson, Perinatology Committee, Foxy, and now is a candidate for Vice President Zone, West Zone, Foxy. Madam, may I request you to welcome everyone?
Yes. So my heartfelt gratitude and thank you to each one of you who are present today. And it is indeed an honor to do this webinar with Ahmednagar Society. First of all, congratulations for pulling off a fantastic grand conference at Shirdi, presidential conference, our very own Sunita Madam's conference, and the way Dr. Ganesh Bade, Dr. Amit, and the entire team who is present here, Dr. Josna and the entire team, they did a fantastic job, and I think all over the country people are talking about the great conference, and I was fortunate to be there and enjoy the hospitality and the warmth of the society. So thank you very much, Dr. Ganesh, for saying yes and for immediately arranging this webinar with Pune Gynec Society. Esteemed guest of honor, Mukta Madam, Dr. Mukta Umarji, who's a guide and whom we look up to for inspiration. Dear friend, Dr. Josna Dhawle, who is always a strong support and always there. And all esteemed faculty, Dr. Bade, Dr. Anil Bendre, Dr. Amit, Dr. Renuka, and Dr. Suvarna. Welcome to Cutting Edge webinar, and thank you for your your presence.
Thank you so much, ma'am. I would like to introduce our guest of honor, Dr. Mukta Umarji madam. Mr. Nandakishore, can we have Mukta madam's slide, please? Mr. Nandakishore, can we have Mukta madam's slide? Okay, by the time they display madam's slide, I would like to introduce madam. It's an immense pleasure and great honor to introduce Mukta madam. I have worked under madam and it's really a pleasure to introduce her. So madam is founder and director at Umarji Mother and Child Care Hospital, which is a specialized center for fetal medicine, fetal therapy and high risk obstetric cases. Madam has been president POGS for the year 2012 and 13. Madam was past Vice President Arogya Bharati Western Maharashtra. She has been past President of Indian Menopause Society Pune chapter. She has been a member of Executive Board of Indian Menopause Society, academic convener for national conferences, Women Health Indian Scenario, Shakti Pune. Madam has also published various papers in National Journal and Foxy Focus. Ma'am has also conducted public awareness programs with various organizations. She has written articles in various newspapers on health awareness. Also has conducted diagnostic camps, workshops for various organizations. A warm welcome to ma'am for the webinar. We are honored to have you here today.
Thank you,
Also, apart
Shubhangi.
from
Thank
that,
you.
yes. Also, apart from that, as I know Madam personally, she's a very soft-spoken person and a great artist too.
Thank you. Thank you very much. Shubhangi is
Yes.
also a very good artist and a very good consultant.
Thank you so
Thank you,
much, ma'am.
Vaishali. Thank you, Vaishali, and wish you all the best. Who is also a very great academician, a sincere worker, good friend, and a very good administrator. And I know you deserve the post, and all the best for that. And thanks the Ahmednagar Society to invite me. It was a really good conference, a best conference, I will say, one of the best conferences at Shirdi. And I heard so many things from so many friends. So all the best to you and everybody for their further endurance. Thank you. Thank you so much and all the best.
Thank you, madam, for your blessings and for your wishes, and you're always there for us. And we really look up to you and try to work the way you do. I have been working with you since when you were president, also POGS, where we did so much wonderful work together. And madam is always there, guiding, smiling, and advising us. Thank you, ma'am. Thank you.
Thank you. All the best. We are all yours.
Thank you.
Thank you.
Thank you so much, ma'am. Ma'am, may I request Vaishali Chavan, madam, to introduce our second guest of honor, Dr. Jyotsna Dole, madam. And Nandakishore, can we have Jyotsna Dole, madam's slide, please?
It gives me great happiness to give a formal introduction of my very, very close and dear friend, Dr. Jyotsna Dole. And she is a senior obstetrician, IVF consultant, practicing for more than 30 years at the grand, huge, big Dole Hospital, which is right on the, I think it is one of the landmarks of Ahmednagar. And also she has been pioneer in starting IVF center at Ahmednagar as early as 2004, 2005, and she has delivered the first test tube baby of Ahmednagar, first ICSI baby, first frozen embryo baby in the entire Ahmednagar district, and she has been.
Vaishali, no. Vaishali, it's okay now.
We remember the AMOGs you held as organizing chair at Shirdi. And it was one of the most memorable events. She's also past President Ahmednagar, and she has received many awards, District Mahila Award by Madhurangan Sarkar for her social activities. And let me tell you that she's a wonderful person, very kind-hearted, very warm, always helpful. And the way she has a huge, tremendous practice, at the same time she manages multi-management, multifaceted personality. So a warm welcome, Dr. Jyotsna.
Thank you so much,
you.
ma'am. Thank you so much, ma'am, for your kind introduction. May I request our guest of honors to say a few words, Mukta ma'am and Jyotsna madam?
Hello.
Yes, ma'am.
Yes, Dr.
Audible?
Please go ahead.
I'm audible? Yes.
Yes,
Yes,
yes.
Thank you, dear Vaishali, for such kind and warm welcome and my introduction. We know each other as a very, very good friend, actually. And as I know, Vaishali is a very hardworking person. Right from beginning, I am observing her, and now she is contesting for the vice president election. So Vaishali, don't worry, we are always with you, and the Nagar Society will always behind you and will support you. No problem. And thank you very much, Pune OBGY Society, for giving me this chance as a guest of honor. Thank you very much. Thank you, Mukta Madam. Thank you, Aarti Madam. Thank you, Vaishali. Thank you, everyone. And we'll start the webinar now.
Thank you, Josna, and all the best for everyone, and Vaishali for your endurance. We are there, and you can ask any help, anything from us. Always.
Thank you, Mukta madam.
All the best.
Josna, thank you so much. Your words,
right.
kind words, blessings, wishes mean a lot to me. And yes, Josna, we know each other since many, many years, and it has
Yes.
been wonderful to have you here today. As long as our has been there, I know your support and love is there. So thank you for the support from Ahmednagar Society as well. So I think we can proceed further. Ganesh sir, would you like to say a few words?
Yes, thank you. I would like to thank Vaishali ma'am and POGS team for arranging this webinar. Now we can start the webinar.
Okay.
yes. Let's proceed to the first session, speaker for which is our respected Dr. Vaishali Chauhan Madam. And the chairpersons for the session are Anil Bendre sir and Amit Karade sir. May I proceed to introduce our chairpersons for first session? First session is preeclampsia, prediction and prevention. Mr. Nandakishore, may I have CV for Dr. Anil Bendre sir, please? Thank you. Welcome to the webinar, respected Anil Bendre sir. Sir is practicing as a consultant gynecologist and obstetrician in Ahmednagar since 1997. He is owner of Bendre Hospital and Maternity Home, Advanced Gynac Laparoscopy and ART Center. Sir has been past secretary and president of Ahmednagar Obstetric and Gynac Society. He has special interest in advanced laparohysteroscopy and ART. Sir has presented various interesting videos and papers at various conferences. And he also has given many lectures on interested topics in laparoscopy and ART in various conferences. I welcome you, sir, for this webinar.
Thank you, sir, Shubhangi. I'm not visible because my camera is not actually working.
Okay.
I
Okay,
tried
sir.
a lot, but it's not working.
Oh. But we can hear you,
I'm
sir.
audible.
Yes, you are
Thank
audible.
you. Thank you.
Yes, thank you, sir. Mr. Nandakishore, can we have Dr. Amit Karade sir's CV? Mr. Nandakishore? Yes, I welcome our second chairperson for the first session, Dr. Amit Karade sir. Welcome, sir. Sir is secretary Ahmednagar Obstetric and Gynac Society. May I request others to mute, please? Yeah. Welcome, Dr. Amit Karade sir. Sir is secretary Ahmednagar Obs Gynac Society. Sir is also joint secretary for IMA. He is a member of FOGSI Environmental Committee and Ahmednagar Obs Gynac Society Medico Legal Committee. I welcome you for this webinar, sir.
Thank you, ma'am.
Yes. So let's start with our first session, preeclampsia, prediction and prevention. May I request Vaishali ma'am to start the session?
I think Dr. Vaishali.
No, sorry. Yes. Yes.
Actually, she doesn't need any
request,
introduction.
May I have Vaishali Chauhan madam slide CV? Amit Karade sir, may I request you, Anil Bendre sir, may I request you to introduce madam?
Dr. Vaishali is one of good friend of mine from Pune. OBGY Society. She is bold, versatile, beautiful, and I think one of the most active members of POGS at present. She doesn't need any introduction as actually. She's clinical director of Cloud9 Hospital currently at Kalyani Nagar. She's director of Sanvi Clinic Women's Health Center, vice president elect of Pune OBGY Society, chairperson of perinatal committee at present Foxy 1820, and
Thank
not at present 1820.
Yeah.
She has many publications to her credit, and she is a receiver of Inspiring Gynecologist West India Award, Health Champion Foxy Award, Legends of Gynecologist Award, and so many.
Thank you.
Lokmat
Thank you.
Award as well.
Yeah.
So I take leisure of means giving her all the best for her candidature of her new post. She's aspiring new post of vice president of Foxy. All the best. We are all behind you, and we'll all serve for you. Thank you.
Thank you.
Thank you for inviting me.
That means so much, and it's an honor that you are chairing the session along with Dr. Amit Karde. Dr. Anil and Smita are my very old and close friends, and our children were also in the same class at
Yes.
Navju. So it's an honor. I'll just share my screen now.
Yeah.
So my talk today is preeclampsia screening, prediction and prevention, and I'll try to quickly finish go through it so that we can listen to an interesting talk by Dr. Ganesh Bade next. So preeclampsia, we know it complicates 4% of pregnancies globally, and even today there are maternal death and fetal and newborn deaths are very much there. We say empowering women has come a long way in India, and there is a decline in maternal mortality ratio, which has reduced from 130 in 2014 to 16 to 97 per lakh live births in 2018 to 20. So we have come a long way indeed. But yet, even today, the mortality associated with hypertensive diseases of pregnancy is more difficult to prevent. And even today, there are mothers who are at risk and there are infants who are at risk. So preeclampsia is a multisystem inflammatory disorder which occurs beyond 20 weeks of pregnancy with proteinuria and blood pressure more than 140/90. It can also affect neurologically, hematological, hepatic, renal manifestation, and of course FGR and so on can also happen. So at our every antenatal visit, as a rule, as obstetrician, we always check for the blood pressure and also a dipstick for proteinuria. But is this enough for predicting preeclampsia? And by just doing these two things, it is just not enough. Earlier, we used to say that preeclampsia is unpredictable, but today things have changed, and today we know that yes, there are ways by which we can predict preeclampsia. Even today, the mothers are dying because of HDP, hypertensive disease of pregnancy. Today, we are losing babies, but if we can predict and prevent, then yes, it will be of tremendous help. So when we talk about screening, there are two things. One is the HDP Gestosis score, and here you just take a detailed history of the patient and you keep ticking marks, and I'll be discussing in detail what is this Gestosis score, and by that we can screen that yes, this patient is high risk for preeclampsia or no. And the second is for high resource setting. Here you need to see the mean arterial pressure, the uterine artery PI, and the PLGF, which is a biomarker. If you combine both these methods, then the prediction of preeclampsia goes very, very high. So the pathophysiology we know is a failure of trophoblastic invasion of spiral artery of myometrium. What does it really mean? It means the spiral artery is near, it's at the base, near the decidua. And what happens is the trophoblast, it invades the smooth muscles of the spiral artery and it replaces the muscle, and the spiral artery becomes big, as is seen in the picture here. So in normal placentation, there is normal trophoblastic invasion, and that spiral artery can vasodilate, can become big, so more blood goes towards the fetus, more oxygen goes towards the fetus. And this trophoblastic invasion occurs at 8 to 10 weeks. Second wave is at 16 to 18 weeks, and it completes by 24 weeks. What happens in preeclampsia is this trophoblastic invasion does not happen, and as a result, the spiral artery remains vasoconstricted, remains small, hence there is less blood flowing towards the fetus, and this leads to FGR and so on. Now, it's interesting to know that the first wave of trophoblastic invasion occurs at 8 to 10 weeks, and the second wave at 16 to 18 weeks. So it's very important to prevent when we start ecosprin that we start it as early as 12 weeks. Probably after 16 to 8 weeks of pregnancy, if you start prophylactic ecosprin, it is already too late. So earlier you start, the better in prevention. So here there is defective trophoblastic invasion, and because of the spiral vasoconstriction, there is endothelial cell dysfunction, and there's inflammatory disorders, and because of this, there is placental ischemia. Now we know the treatment for severe preeclampsia or eclampsia is to deliver. Once you deliver the baby and the placenta comes out, that is the treatment. That means something is wrong with that placenta. So what happens is that this placenta undergoes ischemia, and there's endothelial activation, there's vasoconstriction. With vasoconstriction, what happens is there is necrosis, and with necrosis, there's release of all these biomarkers. And the biomarkers that we are going to talk about are nothing but which are used for prediction of preeclampsia. So with severe vasoconstriction, there's abruptio, there's FGR, preeclampsia, stillbirths, and HELLP syndrome. So when there is vasoconstriction of the spiral artery, the uterine artery flow is less, because there's a uterine artery, and it once the flow is reduced. So because of the placental dysfunction, what are the things that happen? There's decrease in the uterine artery flow, and that is why uterine artery PI is one of the indicators for prediction. There's reduction in the PAPA, there's reduction in the placental growth factor. Because of the vasoconstriction, SFLT, that is the tyrosine, is released, and it goes and binds to the VEGF factor, that is the growth factor, and because of that, the growth factor reduces. So this vasoconstriction of spiral arteries causes a rise in the FLT, that is the tyrokinase, and the fall of the PLGF, placental growth factor, and VEGF. And all this leads to end organ damage with hypertension, proteinuria, and there's necrosis overall. So coming back to prediction, that was the pathophysiology. So there's this Gestosis SDP score. It is practical, doable, very easy, can be done in everybody's clinic. And if you train your staff, they can also give you. And on the other side, that is a universal setting and high resource setting. You have the uterine artery Doppler, the mean arterial pressure, and the biochemical markers like PAPA, PLGF, and FLT, and so on. So PAPA, now PAPA is something, we do double marker for each and every patient. If the PAPA, if you just look at the double marker report, and if you see that the PAPA is less than 0.35 MOM, then yes, this means this could be one of the predictors. But on its own, it is a poor predictor, but it at least gives you an ounce of suspicion that yes, this could lead to preeclampsia. So the first trimester screening is very important, and the various biochemical markers that we are looking into because of the spiral artery, severe vasoconstriction, and necrosis, all these biomarkers are released, and in various, there's increase in the decrease in the VEGF, increase in the tyrosine kinase factor, placental growth factor reduces, and There are also biochemical factors like soluble endoglin and glycosylated fibronectin. These are all products of defective placentation. So there are various guidelines, NICE guideline, ACOG, and RANZOC guidelines, and in which they have seen but to predict, we should know which are the high risk factors, which are the moderate risk and low risk. And once you identify the high risk factor, you can put the patient on prophylactic ecosprin 150, aspirin 150 milligram, one at night. High risk factors are previous history of preeclampsia, chronic hypertension, autoimmune disease, diabetes, chronic disease, and so on. And most of them, the factors are similar for all these guidelines. Moderate risk factor, even nulliparity is supposed to be a risk factor for preeclampsia. Age more than 40, yes, is a risk factor. Or if the interval between two pregnancies is more than 10 years, then again that is a risk factor. BMI more than 35, multifetal gestation is again a risk factor. The only difference between NICE and ACOG guidelines is ACOG has also included the Afro-American and they have taken it as moderate factor, and the age they have taken as more than 35 as against NICE guidelines where they have taken high risk as age more than 40. And in all of these guidelines, they have said that aspirin dose 75 to 150 milligram should be started from 12 weeks of pregnancy. So these are the various predictors. Uterine artery flow velocimeter needs to be done. And earlier we used to look for the notch, but no more. We look at the PI and mean arterial pressure. There's a specific way of taking this mean arterial pressure. The patient should be sitting on the chair with a table with the two hands. And at the same time, on both sides, blood pressure should be taken. 2 readings on each side, and the average of both is the mean arterial pressure. So it is little tedious process, that you make the patient sit and you take 4 readings, but that is the correct way of estimating, of predicting preeclampsia. And this is something which we should be doing in our OPD every day. The NHS, the NICE guidelines and ACOG guidelines, we have gone through this. These guidelines combined with uterine artery Doppler, mean arterial pressure, and the biochemistry gives a very high predictive incidence, like we can predict at a very high level, as high as 99% is and if you combine all these factors, and you can predict preeclampsia as high as 80 to 100%. So these are very simple ways of predicting. Now, maternal risk factors, we already went through all the factors, and all these parameters that you estimate, you put in through the algorithm. It is a logistic regression model, and if you put in an algorithm, if feed in all these findings, then you get the prediction. So this is a very interesting article in the New England Journal of Medicine, the predictive value of SFLT by PLGF ratio in women with suspected preeclampsia. And in this, if the ratio is less than 38, means it is patient is at low risk. If the ratio is 38 to 85, then there's moderate risk. And if the ratio is more than 85, there is high risk. This again, the FIGO also supports this, that published algorithms should be used for converting the measured values. Whatever values you have measured, mean arterial pressure, PLGF, and so on, they should be, the published algorithms should be used for this. And this is the best practice recommendation. Now, what are the new kits on the block is the ophthalmic Doppler. And we are still awaiting studies, but yes, this is a good predictor. Also, there's a huge unmet need for diagnosis and prediction. What we spoke about is what happens in a high resource setting. What about an Indian and innovative screening tool for prediction of preeclampsia? And this is the Foxy-Gestosis ICOG, HDP GCPR, which was released in 2019. And under the Foxy president, Dr. Nandita Palshetkar, Dr. Suchitra Pandit, Dr. Gorak Mandrapkar drafted this, and with Gupte sir and Dr. Alpesh Gandhi and the entire team. So there's a process of risk scoring, which I was talking about, which we should have in our OPDs, and where you categorize patients as mild, moderate, and high risk. And each risk factor is given a score of 1, 2, 3. For this, you need a careful history. And at the end of the taking the history, you sum up the score. And if the score is more than 3, then yes, this patient is at high risk. So this is basically based on clinical history. And in this, only the history is taken. It does not recommend any additional testing. Anemia, GDM, hypothyroid, and mean arterial pressure and maternal weight gain are 5 dynamic factors which can be assessed in each trimester. So these are the risk factors which have score, and the scoring is given accordingly. Age older than 35 is score 1. Age younger than 19 is score 1. Anemia is score 1. Obesity is again score 1, and so on. This is available as an app also on Android phone, and this is available on Foxy website. Like multifetal pregnancy score 2, hypertensive diseases during earlier pregnancy is score 2, gestational diabetes is score 3, chronic hypertension is score 3, mental disorders is score 3, thrombophilia is score 3, autoimmune disorders is score 3, and conceived by ART is again score 3. So when you take the detailed history, you go on ticking and putting the score, and at the end you tally the score. And if the score is equal to 3 or more than 3, then yes, this patient is this a strong predictor for preeclampsia. So comparison with other guidelines also say that clinical risk factor based screening is recommended. And with this screening, this is the time to start prophylaxis in the form of low dose aspirin. So low dose aspirin is recommended for high and moderate risk factors. For low risk factors with previous uncomplicated full term delivery, routine low dose aspirin is not recommended. Also, comparison with NICE guidelines, it is said that clinical risk factor screening is recommended to start prophylaxis with low dose aspirin from 12 weeks of pregnancy till 36 weeks of pregnancy. So all these guidelines also recommend this. There's a lot of clinical evidence and Indian studies. There was a Jammu study which has validated Gestrosis score, and it is an effective screening tool with 80% sensitivity and 90% specificity. And many studies are still ongoing in different parts of India. So what next? Once you have identified, yes, she is high risk for preeclampsia, we should give the patient low dose aspirin as early as 12 weeks until delivery. And low dose aspirin has very good maternal safety. And these are the various studies which support, and lot of evidence which supports the use of low dose aspirin. So internationally also ACOG NICE also recommends the clinical risk-based screening, and HDP Gestrosis score is practical, doable, and a promising tool which each and every one of us should be using. So choose the right investigation for the right pregnant patient. And all these screening methods are really, many of them are not cost effective, but simple detailed history can be cost effective. And start tablet as low dose aspirin before 16 weeks of pregnancy. Based screening should be based by history. So in conclusion, the right to survive pregnancy in childbirth is a basic human right which every woman should get. With this, I thank you all for patient hearing, and I seek your blessings and support for the post of Vice President Foxy West Zone. Thank you.
Thank you, Vaishali, for your nice and deliberate and crisp presentation as usual. We have very nicely explained how to screen the patients, because it is patients for PIH, because it is one of the major cause of maternal mortality as of today, especially in developed countries. So I think clinical screening is very important, as you already rightly said, and EcoSprin can be a very nice treatment for all these patients who are likely to have and likely to develop preeclampsia. Thank you so much, and I wish you all the best for your candidature. I will have to leave for some other program.
Yes, thank you, Dr. Anil, for your expert comments and for your very kind words and for your support. And thank you for being with us today.
Thank you. Thank you. Bye bye, Ganesh. Bye.
Yeah. Dr. Amit is there. Dr.
Yes.
Amit.
Thank you, sir.
May I request Amit Karade, sir? Amit, sir, are you there? Hello?
Amit, sir, had joined actually.
Sir had joined, but I think he had some technical problem. So, sir was supposed to conclude the session.
Yes. Ganesh, sir, would you like to say something?
Yes. Vaishali ma'am has explained everything in detail. And low dose aspirin, she has mentioned it's either 75 or 150. So, is there any study that 150 is better than 75 or else?
No, sir. Actually, what is recommended, different guidelines give different. There's one guideline which gives at 81 milligram also. So 75 or 150 are very, very low dose, and there are no associated adverse effects. 150 is what is recommended, and 150 should be given, but not less than 75 and not more than 150. That is what is recommended. And what is interesting to know that it should be given at night. Patients usually take, sometimes if we don't guide them, they take in the morning. But it's best to give it at night. Because most of this thromboembolic phenomena happen early morning. And when that is why cardiac patients also are given, people with, they usually are given advice to take at night. So
Right.
that is a correct way of taking. Yeah.
Yes. Thank you, ma'am. Thank you.
Yeah. Thank you, sir.
Thank you so much, ma'am. I think Amit sir had some technical problem and he is logged out. Thank you so much, ma'am, for the wonderful presentation. The slides were amazing and like easy to understand. Let's move towards our second session. Dr. Sandhya Mishra, madam, can you take over the second session? Can you introduce chairpersons for second session?
Yeah, thank you, Shubhangi. So with this, we begin with the next session. And for that, I call upon the esteemed chairpersons. Our first chairperson for today is Dr. Renuka Pathak. Can I have a CV, please? So Renuka madam, she's a consultant obstetrician gynecologist, endoscopist at Swasthya Hospital and Medical Research Center for the last 17 years. She has special interest in high-risk obstetrics. She has done her diploma in hospital administration and in 2015, and then she was medical superintendent at Swasthya Hospital. She was a part of the scientific team in AMOX 2016, organizing secretary of EVCON 2015, secretary of Ahmednagar Society from 2019 to 21, and she was the president of IMA Ladies Wing Ahmednagar from 22 to 24. Welcome, madam. Yeah, so
Thank you.
Yeah, welcome, ma'am. I call upon the next chairperson for today's session, Dr. Suvarna Hoshing, ma'am. Welcome, ma'am. She is the director of Hoshing Hospital, practicing gynac since 10 years at Ahilyanagar. She is a fertility specialist and laparoscopy surgeon, and with special interest in high-risk obstetrics. She is the treasurer of Ahmednagar Society. Welcome, ma'am.
Thank you.
Yeah, Dr. Shubhangi, you can take it from forward from here. Hello.
I request Renuka Pathak madam to introduce the speaker for session 2, Dr. Ganesh Bade sir.
Yes.
May I have Dr. Bade sir's slide CV? Renuka ma'am, a request
Yes.
if you can introduce sir.
Yeah. Good evening, everyone. Thank you, POGS, for conducting such a nice webinar.
Actually, it's such a easy way of connecting and enriching our knowledge by sharing our ideas through Zoom, which we've all learned after COVID that we can have such meetings. And very good initiative. Thank you, Dr. Shubhangi. Introduction of our president, Dr. Ganesh Bade. For Nagar people, I don't think he requires any introduction. But for Pune, the people in Pune, I would like to give his short introduction. So he was the chairperson of the presidential conference at Shirdi, worked as a secretary and treasurer in AUGS. He was a joint secretary at AMOGS in 2016. He is the director of Bade Hospital and Laparoscopic Center, and he has also worked at the civil hospital as a gynecologist for 7 years. But more than this, Ganesh Bade sir is known for really helping out all gynecologists in difficult situations. Wherever there's an obstetric hysterectomy or an internal iliac ligation, Ganesh is just a call away. Many times we call him as Sankat Mochak, that he really comes to save us. And so today I would really welcome to hear about from Dr. Ganesh regarding the next talk. So thank you very much once again. And Dr. Vaishali, a very nice talk given by you on hypertension. Very nice. And that is the thing that we are daily seeing. We are still not able to stop preeclampsia, hypertension. It's still there, and we have to manage those patients. So we need to revise and get new ideas and get new info regarding newer tests, newer modalities of treatment. So thank you very much, Dr. Vaishali, and all the best for your campaigning as a Vice President West Zone. Thank you.
Thank you so much, ma'am. Let's move towards our second session, basic yet very important topic, that is role of FCM in the management of iron deficiency anemia. May I request Bade sir to start the slides, sir?
Thank you, Redeka madam, for the kind words and introduction. Thank you, Dr. Vaishali madam, Shubhangi madam, and the all team POGS for giving me the opportunity. Can I have my slides, or should I?
Mr. Nandakishore, you have sir's slides with you? आपके पास नहीं है?
Yes,
Sir, can you share it from your screen?
Yes, ma'am.
Yes. So have you logged in from the desktop?
Yes. I'm logged in from the desktop.
Sir, if it is saved on the desktop,
Mr. Nandakishore actually has, Sandhya has said. So he will start the presentation. Mr. Nandakishore, will you start?
Thank you, sir. As we all know, iron deficiency anemia is losing the metal. In iron deficiency anemia, HB synthesis is limited due to lack of iron and consequently rendering the person anemic. According to WHO, anemia in pregnant women is defined as HB concentration less than 11. Iron deficiency is the most common cause of anemia during pregnancy. Next slide. This is the incidence all over the world. In developed countries, the incidence of anemia is 14%, while in developing countries, it is 56%. Iron deficiency anemia was estimated to cause 22% of the maternal deaths. Over a third of all the pregnant women, around 30 million, are anemic. Next. Is concern about iron deficiency anemia during pregnancy. In India, there are almost 326,000 estimated maternal deaths due to iron deficiency, and associated disabilities are around 1.25 CR, life adjusted years, disability adjusted life years. Next. This is the determination of anemia in women of reproductive age, and these are the causes. The anemia mostly due to decreased erythrocyte production or increased erythrocyte loss. As there may be decreased production due to genetic hemoglobin disorders, blood loss, as we know, hemorrhage, and increased erythrocyte loss in poor nutrition and exposure and response to the infectious diseases. So, maternal causes mostly early onset of childbearing, high parity, short birth spacings, and pregnancies and lactation status. Dietary intake is less as there are access to diverse food sources, access to enough food, and access to the fortified foods. Socioeconomic factors like education, household wealth, and urban-rural residence is also their causative factor. Ecological factors like political, economic, climate, and environment, health policies and systems by the government, cultural norms and behavior, gender equity and empowerment. So, socioeconomic causes, dietary factors, and some genetic disorders can lead to anemia. Next. This is pathophysiology of iron deficiency anemia. Is dilutional effect. During pregnancy, there is a dilutional anemia due to increased blood volume, expansion around 50%. Placental development, that's some organs are metabolically active organs and have large iron requirements like placenta, and fetal requirements, metabolic and oxygen delivery needs during fetal growth. Next. Iron requirement is 9 times higher during pregnancy. As we know, there is a gross iron demand during pregnancy. Obligatory iron loss is 0.8 milligram into 290 days, around 230 milligram. Increase in red cell mass 450 milligram. Newborn baby weight 3.5 kg, so 270 milligram. Placenta and umbilical cord requires 90 milligram. Blood loss at delivery around 200 milligram. Total gross is 1,240 milligram iron is required during pregnancy. Next. Anemia screening in pregnancy. These are the guidelines. ACOG guidelines. Anemia screening is recommended in first trimester and again at 24 to 28 weeks of gestation. Screening of anemia at booking. RCOG recommends at booking and at 28 weeks. Women with multiple pregnancies should have an additional CBC done at 20 to 24 weeks. Next. Diagnosis of iron deficiency in pregnant women is usually we do hemoglobin concentration, HB, and it is widely available, ease of measurement, low cost, lack of sensitivity to detect early stage of iron deficiency cannot be utilized to diagnose conditions other than iron deficiency anemia. So HB is the basic screening test we usually use for the diagnosis of iron deficiency. Next. Iron specific biomarkers help to distinguish iron deficiency anemia. So other iron biomarkers as shown, that is serum ferritin, total iron binding capacity, hepcidin. So derived from the measurement of transferrin, that is a iron binding capacity. Hepcidin is inversely proportional to the iron therapy required. Next. So newer red blood cell parameters for iron deficiency anemia. The advanced red blood cell reticulocyte indices such as hypo-R, CHR, and hypo-EM have marker of iron deficiency erythropoiesis. CHR is a reticulocyte hemoglobin content. That is a hemoglobin content per reticulocyte. Hypo-EM is hypochromic microcytes, percentage of hypochromic microcytes in the slide. Hypo-R is a hypochromic reticulocyte. So postpartum anemia effects and causes. Iron deficiency anemia in pregnancy is closely associated with occurrence of anemia after delivery and in postpartum period. Postpartum iron deficiency anemia causes an impaired quality of life in the physical and mental health of the woman. Development of postpartum anemia because of presence of prepartum with magnitude of peripartum blood loss. Next. Diagnosing postpartum anemia. If HB less than 11 gram per deciliter in first week of delivery, we call it as an anemia. In such scenario, less than 11 is almost 80% will be anemic. And HB less than 12 gram after 1 week of delivery will label as the anemic. Major causes of postpartum anemia are unresolved antenatal iron deficiency in many women during pregnancy, and excessive blood loss. Next. Complications related to postpartum anemia. There are symptoms like tiredness, palpitation, breathlessness, infections, particularly in urinary tract infection. It also leads to reduced cognitive performance, induces emotional instability, distress, and increase the risk of postpartum depression. May causes women to experience difficulties in caring for their newborns. Next. Treatment modalities. As we have to lifestyle modifications, dietary modifications, supplementation, pharmacotherapy, and lastly, blood transfusion. Next. Lifestyle associated problems and need of modification, mostly iron deficiency anemia leads to low birth weight and preterm delivery. Lifestyle smoking is a detrimental lifestyle habit during pregnancy, and we should advise to stop smoking. And tea and coffee, that tannins from tea and coffee are known to inhibit the iron absorption from the food. So coffee and tea should be reduced. Next. Nutritional supplementation of iron is lower than the need during pregnancy. First trimester, we need 35%, then second 37%, and third trimester 41% of iron supply during pregnancy. We need to increase the iron supplementation first, second, and third trimester. Next. Dietary interventions to improve. We should advise what iron-rich diet supplementations like green vegetables, then give non-vegetarian diet like chicken and meat, cereals and pulses, and fruits like beetroot, then apple. These are rich in iron supplements. So dietary advice should be given properly. Next. diet, those ascorbic acids and fruits, that citrus fruits containing vitamin C should be advised, as they increase the absorption of iron. Next. Supplementation is the key. In absence of supplementation, loss of bone marrow iron store is triggered in women. Decrease in serum ferritin and decrease in HB of nearly 0.5 gram per deciliter is recorded by the end of pregnancy. Depletion of iron stores consequently leads to iron deficiency and subsequently iron deficiency anemia. Next. Management of iron deficiency anemia. If hemoglobin is less than 11, we should do ferritin levels. If ferritin is less than 30, then if pregnancy is less than 14 weeks, oral iron will suggest, and will repeat CBC after 4 to 6 weeks. If hemoglobin is 9 to 11, oral iron trial for 4 to 6 weeks. And if still iron is HB is not improving, then recommend IV iron if anemia is persist. Hemoglobin is less than 9 and patient is high risk, recommend directly IV iron. If pregnancy is more than 28 weeks, I recommend directly IV iron, replete the iron deficit, usually at least 1 gram for moderate to severe anemia. If ferritin level is more than 30 and MCV is less than 80, recommend hemoglobin electrophoresis for alpha thalassemia testing. And if MCV is more than 90 to 100, then recommend obtaining B12 and folate levels. Recommended iron doses on oral daily or every other day iron, avoid dosing 2 to 3 times daily. IV iron sucrose 200 to 300 milligram. And high risk factors are bleeding disorders, chronic placental abruption, history of gastric bypass. These are the high risk factors. Next. Oral iron is considered the first line of treatment of iron deficiency anemia. Next. The absorption of oral iron increases with increasing dose of oral iron only up to 160 milligram per day. So, higher serum ferritin levels are observed when they're taken between meals or at the bedtime. Dose of oral iron is directly proportional to the improvement in HB level. However, mild GI disturbance is expected. Alternate day dosing of elemental iron is known to significantly increase the total iron absorption. Next. A cursory glance on at oral iron formulations. As we know, ferrous iron salts are the most commonly used, inexpensive and widely available, but there is a tendency of gastric upset. Polysaccharide iron complex are potentially low risk of gastrointestinal intolerance, better taste profile, less effective than ferrous salt in at least one randomized clinical trial of children's. Heme ions now available is higher absorption rate, but it is expensive. Carbonyl iron are inexpensive, no clear efficacy or side effect benefit as compared. Iron protein succinates, these are the now available, but data is limited. Iron amino acid chelates, these are less susceptible to dietary interactions, may be more expensive than the ferrous salts. Next. Drawbacks of oral therapy are adverse effects, insufficient length of therapy, long course of therapy is required, and lack of adherence to therapy, limited duodenal absorption due to concomitant GI pathologies. Next. Blood transfusion as an anemia correction therapy. Blood transfusion is an effective method to treat anemia. Effective in patients with severe iron deficiency. Rapid anemia correction is clinically necessary, and when patient shows no response to dietary or iron therapy. And when it is an emergency, we have to do blood transfusion. Next. However, blood transfusion is associated with the risk. As we know, blood transfusion should be considered as a last resort, as there is anaphylactic reactions or mismatched blood transfusion or chances of serious infections like HIV or HBsAg. Postpartum transfusion reactions are there. Next. Then comes IV iron in pregnancy. If intravenous iron is suggested when there is no improvement with oral treatment, developing side effects with oral therapy, and severe iron deficiency anemia required rapid interventions. Administration of IV iron is restricted to the second and third trimester of pregnancy. Next. Intravenous iron sucrose. Previously we used to use iron sucrose. A recent studies finding demonstrates safety of IV sucrose being compared to standard oral iron therapy in pregnant women. Minor side effects are reported, and iron sucrose is to be administered at low dose through multiple visits. It is a safe iron sucrose, but it requires multiple visits. Next. Intravenous low molecular weight iron dextrans. Low molecular weight iron dextrans. Several studies reported the safety of low molecular weight in a pregnant woman. Considering the pre and post treatment data, it was demonstrated that post treatment with HB concentration rise up 9.7 gram per deciliter to 10.8 gram. Elevated transferrin saturation from 11.7 to 22, and ferritin level increase significantly from 14 to 126 nanogram per ml. Next. Newer intravenous iron formulations. As we know, we are using it now. Ferrous carboxymaltose, FCM, then iron isomaltoside, and ferumoxytol. FCM is a parenteral iron dextran. It is a dextran-free product approved for rapid and high-dose iron replenishment. It consists of ferric hydroxide core and a carbohydrate shell, allowing controlled iron delivery. Next. Side effect associated with intravenous iron. This low molecular weight iron dextran, there is a slightly high risk of anaphylaxis. More recent data has shown similar safety profile to other common products. Then ferric gluconate, hypotension and flushing, headache. Iron sucrose has some diarrhea, headache, nausea. Ferrous carboxymaltose is safer than the previous one, but there is a hypophosphatemia risk is slightly there. Next. Next. Ferric carboxymaltose as a therapy in iron deficiency anemia is recently it is getting popular. It is a dextran-free parenteral iron, offers rapid and high dose replenishment of depleted iron stores. FCM is an iron complex consisting of ferric hydroxychloride or stabilized by carbohydrate shell. Next. FCM permits the administration of large doses in a single setting. FCM has low immunogenic potential, which shields it from high risk of anaphylaxis. The design of FCM permits controlled delivery of iron, preventing the release of large amount of iron into the serum. This permits large doses of FCM, 15 mg per kg, maximum of 1 gram infusion in a single rapid 15-minute session. Next. Pharmacodynamic of ferric carboxymaltose is 61 to 99% RBC uptake of iron and 91 to 99% uptake of radio-labeled iron in patients with iron deficiency. There is 61 to 84% RBC uptake in patients with renal anemia. Next. Pharmacokinetic of ferric carboxymaltose. After a single 100 mg IV iron dose of FCM solution injection over 1 minute, serum iron concentration peaked at a mean of 15 minutes. There is 2.6 to 4.4 ml per minute mean plasma. Summary of previously reported PROMISE studies. A retrospective observed a real-world study of 1,800 patients with iron deficiency anemia. The assess the efficacy and safety of IV FCM in adolescent and adult. Next. FCM in the management of iron deficiency in pregnancy. So it shows that pregnant woman with iron deficiency anemia, 4 to 12 gram per deciliter, and we should exclude anemia other than iron deficiency anemia, HB less than 4, first trimester pregnancy, hypersensitive for FCM, and malignancies and iron overload conditions. Next. FCM in the management of in subgroup analysis. So there is a significant difference shown. The hemoglobin rise is good, ferritin level is maintained, then hematocrit is also increased. So all parameters are really improved nicely with FCM. Next. FCM in management of iron deficiency anemia, HB increased by almost 3.6 gram per deciliter and serum ferritin by 16.9 in women with severe iron deficiency. In women with moderate, there was an improvement of 2.7 and serum ferritin by 33 microgram. In women with mild iron deficiency, a rise of HB is 1.99 gram per deciliter in HB level and was recorded a good improvement with FCM. Next. FCM in management of iron deficiency. So IV FCM is associated with favorable safety in all the severities, and the physician's favorable assessment of FCM efficacy and safety in women with iron deficiency affirms the use of daily clinical practice. We can use it regularly in mild, moderate, and severe cases. Next. Comparison of FCM with other iron treatment for anemia in Indian pregnant women. So the chart shows FCM single 1 gram injection is a crucial treatment for correcting anemia and restoring iron store in pregnant women experiencing moderate to severe anemia in the late second or third trimester. Next. Ferric carboxymaltose versus iron sucrose complex comparison. The mean rise of HB at 12 weeks was significantly higher in FCM group, and FCM was associated with greater improvement in fatigue score, and the number of visits was significantly less in FCM group. No serious adverse effect has been noted in the FCM group. Next. Next slide. As we see in comparative study, side effects associated with FCM are commonly headache, dizziness, hypertension, flushing, nausea, and injection site reaction and hypophosphatemia. And rare side effects are dyspnea, tachypnea, tachycardia. Okay, next. To summarize, iron deficiency anemia may lead to preterm labor, placental abruption, severe PPH, and preeclampsia. So, due to PPH, we may have to go for the interventions like internal ligation, hysterectomies, then maternal shock, increased ICU administration, and lastly, maternal death. Next. Next slide. These complications, we have seen that preterm birth, low birth weight, small for gestational age babies, and fetal distress, memory and processing disorders, intellectual disabilities, and iron deficiencies in the offspring babies also. Next. So what makes the ferric carboxymaltose a better choice? FCM offers advantages of large dose administration per sitting, which translates the better patient compliance, then fewer number of hospital visits, less discomfort to the patient due to needle prick, and in pregnancy, FCM has been demonstrated to improve QOQL score and fatigue level when compared with the standard parenteral iron therapy. FCM is also reported to provide rapid elevation of HB level in pregnancy. Next. FOXY recommendation for FCM. Among the various preparations of parenteral iron supplementation, FCM was found to be possibly better than the other parenteral iron. FCM is a dextran-free IV iron preparation that allows rapid administration of high dose of iron up to 1 gram iron in 15 minutes. FCM administration is postpartum has been found to be safe and effective in improving the mean hemoglobin level. Compared to other parenteral irons, FCM has several advantages and it has fewer side effects. Single high dose administration is the possible and it can reduce the frequency of hospital visits. Next. FCM also has the age in postpartum anemia. From among wide number of preparations of parenteral iron, FOXY confirms FCM as the best option for postpartum. In addition to the advantages of ease of dosing, studies demonstrated the better safety and efficacy profile associated with FCM in PPA. Additional FCM has been considered an optimal choice for PPA considering the GI intolerance associated with oral FCM. Expert recommends FCM as a choice of iron supplement in postpartum anemia to rapidly and effectively correct iron deficiency, replenish iron stores, and raise HB to optimal level. Next. Guidance note on use of intravenous iron among the pregnant women. More than half of the pregnant women in India suffers from anemia, defined as a hemoglobin less than 11. At any time during pregnancy, it is further classified as follows: known anemia more than 11, mild 10 to 10.9, moderate 7 to 9.9, and severe less than 7. Next. So, guidance note on the use of intravenous iron among pregnant women. FCM brings about greater and faster hemoglobin increase in treatment of anemia. FCM exhibit higher stability and antigenicity was much lower with FCM in comparison to iron sucrose. So FCM usually requires shorter administration time, approximately 15 minutes, compared to iron sucrose, which makes around 30 minutes. Maximum dose and total replenishment dose in single infusion is higher for FCM, allowing for efficient delivery of substantial amount of iron in one administration. Next. So, what are the indication and contraindications? In indication, moderate anemia during pregnancy after first trimester, oral iron not tolerated, non-compliance to oral iron, no improvement of HB or improvement less than 1 gram per deciliter after 1 month, moderate anemia after 32 weeks of pregnancy, and severe anemia due to iron deficiency at 13 to 14 weeks of pregnancy. So contraindications are evidence of iron overload, then serum ferritin more than 150, known hypersensitivity to FCM, anemia not caused by iron deficiency, liver disorder like jaundice, cirrhosis, or renal failure, acute cardiac failure, and known case of thalassemia disease, sickle cell anemia disease, or hemolytic anemia. Next. This is how to administer FCM. FCM is available in 10 ml and 20 ml vials. Each 10 ml vial contains 500 milligram FCM and 20 ml vial contains 1 gram of FCM. FCM will be administered as an intravenous infusion based on the calculated dose required with 100 ml of 0.9% normal saline solution over 15 minutes. The maximum dose per session will be 1 gram. If subsequent doses are needed, 7th and 14 days can be planned to administer. FCM should be administered at PSC or higher level under the supervision of medical officer. Vital signs such as blood pressure, respiratory rate, temperature, and fetal heart rate should be monitored. To avoid permanent discoloration, the intracatch should be in the vein only. And you should confirm the patency by injecting the normal saline. Pregnant woman should be observed for 30 minutes after the FCM infusion. At least a test dose is not required for FCM. Next. And to summarize, iron deficiency is the most common cause of anemia during pregnancy. Treatment aspects of iron deficiency include lifestyle change, supplementations, dietary modification, transfusion, and pharmacotherapy. FCM has demonstrated therapeutic efficacy for conditions associated with absolute or functional iron deficiency, either with or without anemia. FCM is reported to be effective in treating iron deficiency as well as postpartum anemia. Studies confirm the safety, efficacy, and tolerability of FCM. Anemia Mukta Bharat guidelines also suggest the use of FCM in pregnant women with iron deficiency anemia. Compared to other parental, this is FCM is the better option. So thank you very much.
Thank you very much, Bade sir, for that very comprehensive and I think in-depth insight on the anemia. Aggressive screening in the reproductive age group of anemia is very mandatory, and it is a leading cause of maternal and fetal mortality and morbidity in current times. It was a fantastic deliberation. We learned so many important points from this session. Like the contraindications, it's a big no in the first trimester to take IV iron, and we should stop oral iron at least 24 hours prior to IV FCM, and start the oral supplementation only after 7 days after IV.
I think connection is lost.
No.
Hello.
Hello.
Hello, Mr. Nandakishore.
Yes,
हेलो, ये थोड़ा कनेक्शन का प्रॉब्लम है शायद.
आवाज
Unmute करा मैडम. डोले मैडम unmute करा.
Hello. Can you hear me?
Yes,
Yes.
sir. Yes.
Thank you, Pune Obstetrics and Gynec Society, for the wonderful webinar, very informative webinar, and my best wishes to Vaishali ma'am for Vice President post-elections. Thank you.
Thank you so much, Dr.
Thank you.
Suvarna, for your wishes and your comments.
Sure.
Wonderful talk, Ganesh sir.
Thank you,
Fantastic.
Vaishali madam. Thanks for the opportunity and best wishes for your elections.
So with your vast
Thank you,
experience,
madam.
vast practice, I know you have given your own inputs into the entire subject. So thank you very much. Yes,
Thank you, dear Vaishali. Wish you all the best.
yes.
Thank you, Dole madam. Thank you.
Yeah.
Thank you, everyone.
We would like
Nice
to
lecture by Dr. Ganesha. Ganesh,
madam.
yes,
Thank
taken
you.
very informative. Thank
So
you.
Yes.
it's a pleasure to propose a vote of thanks. So thank you, everyone. Mukta ma'am, Jyotsna, Dr. Jyotsna, Ganesh sir for his fantastic talk, Dr. Anil Bendre, Dr. Amit Karade, Dr. Renuka Pathak, Dr. Suvarna Hoshing, and our very young coordinators, Dr. Shubhangi and Dr. Sandhya Meshram, and of course BSV for giving us the academic support, and our own POGS team, Dr. Aarti, Dr. Meenakshi, Dr. Amol. It was a pleasure to have you all, and I tried connecting earlier with Ahmednagar Society, but you were very busy with the big grand conference. So thank you for the opportunity. It was wonderful to connect with you all.
Thank you, madam. Thank you.
Thank you very much.
Thank you.
Thank you so much,
Thank
ma'am.
you.
That
And
was
all the best for everyone.
Okay,
Okay.
bye-bye.
Bye-bye. Bye-bye. See you soon.
Thank you so much, ma'am. Thank you. That was a wonderful webinar, and we request that Madam is we remind again that Madam is
No, it's,
contesting for our.
Shubhangi, we
Yes,
will try
yes,
to send the link in the
Okay.
group of the
Okay,
webinar.
ma'am. All right, ma'am. Thank you. Thank you, everyone.
Thank you.
Thank you, ma'am.
Sandhya, next, I think very well done, Shubhangi.
Thank you, ma'am.